Assalamualaikum warahmatullahi wabarakatuh to all my junior doctors, especially surgical residents, hospital special, especially. Okay, as promised, I'm going to share with you how we manage upper GI bleed. Okay, as we understand, whenever patient presented with hematemesis and melena, we can actually divide the cause into variceal or non-variceal bleed. So variceal and non-variceal bleed. I discussed already about non-variceal bleed. Now we are concentrating on variceal bleed. Esophageal varices, though the name is scary, it is not the most common cause of upper GI bleed. See, the most common cause is chronic peptic ulcer disease on aspirin or patients on steroid with comorbid. So usually upper GI bleed secondary to esophageal varices listed at number 3 or number 4. But if it presents to you with esophageal, it is required acute surgical intervention. Mean you have to do it fast, you have to correct it fast, you have to intervene it fast because the bleeding is torrential. Is what you call that? Manga is actually you can make a provisional diagnosis during history itself. And during history, the patient usually give you some features of liver disease, like previous history of bending before patient cirrhotic, a case of cirrhotic liver, hepatitis, jaundice patients. So these are the kind of patients that you have to think that most likely the cause of bleeding is from esophageal varices. So after you get the history, quick clinical examination, you will find the evidence of liver cell failure. I'm not going to discuss in detail. Jaundice, petechiae, bruises all over. Okay. So when you work in the hospital where the facilities of scope is available, and this patient admitted from ED and then diagnosed upper GI bleed secondary to diabetes, and you know the diagnosis as esophageal varices, do not insert a rice tube. Okay, please do not insert the rice tube because you will further causing damage to the varices. Do not insert the rice tube. Resuscitate the patient properly, maintain the hemodynamic stability of the patients, admit the patient to the ward, acute ward, and monitor, and prepare patient for the scope. If patient is comfortable, is not bleeding, hematosis in front of you until the GCS drop, and see the conscious level whether this patient into hepatic encephalopathy or not. So resuscitate properly, get the BP, everything stable, put to the ward, and then correct the whatever coagulopathy have presence, and then subject patient for scope. Okay, during the scope, we have the options of bending the varices and also rule out fundal varices. If fundal varices, we can inject with histoacryl. Start patient on sandostatin. You can start at ED level if you make a clinical diagnosis, sandostatin infusion, or you can start patient on telepressin. Okay, which one available in the hospital? So study has said that if you band together with sandostatin, the risk of rebleed is less. The means the treatment and the monitoring is much more effective rather than monotherapy alone. Okay, you band, put on sandostatin, monitor the patient in acute bed or ICU. Let's say you fail to band. You fail to band. So after multiple attempts, so patient deteriorating. Refer the patient to ICU, get the patient intubated, make sure the airway is controlled, then we insert sense taken tube. Okay. Nowadays, we have 4-lumen sense taken tube, previously known as sense taken Blackmore 4-lumen, jadi Minnesota tube. So you insert the sense taken tube overnight. Do not attempt until the patient collapse and nothing much can be done. So the tips to put inside second tube, you must make sure patient is comfortable and you as well comfortable. Don't struggle to insert test tube when patient is fighting, because it's not difficult. You insert normal rice tube in people, in normal patient in the world also difficult. So make sure patient is stable, maintain the airway. So preferably get the ICU, intubate the patient first, then only you push in the sense taken tube. Okay, sense taken tube. I don't have sense taken tube with me. Okay, so you put in sense taken tube like you put in rice tube. So you measure, all right, 40 centimeter. Okay, at 25 centimeter, after that 27 centimeter. When you feel the gas, put a stethoscope and then you flush in air. The tip is in the stomach. You fill in the gastric balloon first with 250 ml of water or this normal saline, no problem. So you flush in, fill up minimum 250 ml and then pull back until it compress the cardiac esophageal junction and it obliterate the bleeding varices. Okay, then you put the pressure at the end of the tube, at the end of the bed, like 1 kilogram of weight or 2 bottles of salines, so that it give tamponade. So if bleeding stop, that is enough. If bleeding is not stopped, you have another balloon, what we call esophageal balloon. Inflate it with air using the blood pressure manometry to the pressure of 30 to 35 millimeter mercury. So this one fail means there is another column of varices is not compressed. You inflate it with esophageal balloon with 30 to 35 mils of pressure with air. So you maintain the pressure for 24 hours. Do not exceed more than 24 hours. Mean if patient is intubated in ICU, the next day make sure you deflate the balloon, because chances of esophageal perforation is higher if you forget to deflate the balloon. It can cause esophageal necrosis. Alright, so deflate after 24 hours, leave the gastric balloons. Then after 48 hours or patient has no more bleeding, you can even take out the second tube and then plan for rescope later. Okay, plan for rescope later. You don't have to rescope immediately because nothing much you can see. You can't even bend the variceal. Okay, and you rescope. Okay, let's say after you rescope, after you bend, what you need to do, you have to start concomitant therapy of propranolol. As long as patient can take already, start propranolol as soon as possible, provided the blood pressure is controlled, 20 milligram BD. Okay, so when patient go home, patient should be on propranolol, 20 milligram BD, and schedule for rescope in 3 weeks times. Rescope in 3 weeks time until the bladder is fully this varices is fully obliterated. Then you can get the appointment for scope. So the underlying causes must be treated. The cirrhosis, hepatitis, all must be treated by medical. Okay, so patient must be aware that this procedure is continuous for lifelong until his liver is corrected. Okay, thank you very much. With that, concluded the short presentation, sharing about the management of esophageal useful to the hospital and junior doctors. Assalamualaikum warahmatullahi wabarakatuh. Okay, this is Malacca Delight Mango. This is like rival to the Perlis Harumanis lah. Okay, if you have the opportunity, get the benih and tanam in your house lah. Small compound also you can tanam. Okay, thank you very much.